Hello everyone, welcome to Medicine with Faizan. I hope you have watched the previous video where I shared some of my experiences of the PACES exam and how I passed the first few stations and passed them with perfection. Now moving on to my fourth station, which was actually the fifth station of the exam cycle. In PACES, the fifth station is usually a long clinical consult. So while I was waiting outside the station, I was handed in a piece of paper which had all the details of what I was going to see inside. Again, I don't remember the exact words of the scenario, exact details, but it was about a middle-aged patient with history of weight gain and amenorrhea. And other significant finding in her vitals was her raised blood pressure. When you read this information, the first thing that comes into your mind is endocrine issues. At the top of my mind was Cushing syndrome, then hypothyroidism, polycystic ovarian syndrome, PCOS. I also wanted to rule out alcohol-related pseudo-Cushing. So when I went in, again, there were two examiners sitting behind the desk. The surrogate was sitting in front of me. The patient was lying behind me on the stretcher. The examiners introduced themselves and the surrogate. Keep in mind that the moment you enter into the station, your 15 minutes of non-clinical consult start right there. Everything that happens after that, including the introduction by the examiners, the surrogate, all of these things, it's included in those 15 minutes. So when you're preparing with your study partner, time your preparation according to that. So I started asking questions from the surrogate. I applied my usual history taking scheme. After the major complaint, I quickly screened about previous medical and surgical condition, any medicines they are taking. They told me about her acne, how it's unmanageable. She's taking some creams and all of that, and medicines. I don't remember the name, but it's not manageable with that. Here, I must mention that my scheme of quickly screening the past medical and surgical, and in fact, the medicines, I don't think the examiners liked it. I don't know. It's my opinion, but I am not sure. Also, in this station, my main focus, since the diagnosis was quite obvious from the outside, my main focus here was asking questions related to relevant symptoms and associated symptoms, and to differentiate between Cushing, whether it is Cushing, hypothyroid, or PCOS. My main focus was this one. And when you are asking questions relevant to associated symptoms, you jump from one system to another, which is relevant to the medical condition. Again, here, I'm not sure whether the examiners like this or not. It should be the routine, I think. But again, it varies from examiner to examiner, maybe case to case basis. Here, I could see from the periphery of my vision at one point that one of the examiners was writing something in my feedback form. In PACES, when the examiner is writing something in the feedback form, it's not a good sign, because they only write in the feedback form, they only provide feedback only when you are borderline in that specific skill or unsatisfactory. When you are doing everything perfectly, when your performance in the specific skill is satisfactory, they usually don't write anything. Again, it varies from examiner to examiner, but mostly it's considered that if the examiner is writing something in the feedback form, it means you have made some mistake. Anyways, I completed the major part of my history. Then I went on to examine the patient. Again, when so much is running into your mind, whether true or untrue, whether you have self-made it or it was the case, it doesn't matter. When so many things are running in your mind, your performance is affected, and that's exactly what happened. I completed all the steps of examination, but I made the made a blunder. The patient was lying in the stretcher. I made her sit up twice. It's not a good thing to do because first it shows you are unstructured, your examination is unstructured, and secondly, it appears to the examiner that you have not practiced this examination enough. And another important thing is when you make the patient change their posture again and again, sometimes if they are suffering from any pain or any tenderness anywhere, changing the posture again and again might aggravate that pain. And if that happens, the examiners are not going to spare you. Anyways, I completed the examination and came back to address the surrogate's concern. Here again, when I was coming back to sit in my chair, I had a quick peek at my feedback form the examiner was holding in his hands, and I could see they had marked me borderline in one of the communication skills. So that confirmed my earlier doubt that they were writing something in my feedback form and I was asking questions. Anyways, I addressed the surrogate's concern and answered, to me, I answered everything appropriately. After 15 minutes, I addressed the examiners and started presenting my case, gave them my top differentials, which were Cushing syndrome, hypothyroidism, and PCOS. The examiners questioned me about how to differentiate Cushing disease and Cushing syndrome and how I will manage if it is Cushing disease and if it is Cushing syndrome. Then they asked me question how to investigate PCOS and how will I manage it. So that was all about the Viva. I think I answered most of the questions. In fact, all of the questions appropriately. This is my feedback form. Overall, it was not so bad. My performance was well above average. But yeah, I did some mistakes and they didn't spare me. They deducted marks on that. But when you have done everything quite well in your previous stations, these little mistakes don't really matter. So my final station, which was actually first station of PACES. In PACES, the first station is further subdivided into communication and respiratory examination. So I was handed scenario of communication outside. To be honest, it was quite confusing. There were so many ambiguities in the scenario. It was about a young patient which had to be investigated for secondary hypertension. He has no history overall, but 2 to 3 readings of high blood pressure. So the consultant, I was the candidate, wanted to investigate him further to rule that possibility out. And the investigation were mentioned like renal Doppler, some other blood tests, and all of these things. But the ambiguity was that was it the only task required of me in those 10 minutes? Because if that's what it was only 2 to 3 minute scenario. Anyways, right there, one incident happened in the exam cycle. The patient from station 2, they didn't want to continue further. I don't know why. They were tired, they were fed up. It was the last cycle of the day. Maybe that's why, or maybe it was getting too late. Anyways, they switched the real patient with some surrogate, but kept the whole scenario exact same. But it gave us some extra time to think about it. Still, I couldn't figure it out. The communication station, I couldn't figure it out. I made some notes, brainstorm. No. Anyways, I went in, started the conversation. I applied here the ICE model: idea, concern, and expectation. Idea about their knowledge of their condition, what they want to know, concerns, and expectation or wishes, how they want to proceed with it or dealt with, managed. Then I asked them quick question about their history, if they smoke, if they have any alcohol history, any sedentary lifestyle, any history of significant blood pressure, or any other condition running in their family. which was all negative. Anyways, I offered them the investigation we were planning. They refused once or twice. I told them it's their autonomy, but still, we as doctors work in their best interest. So it is quite advisable that we go with those investigations. Then again, the surrogate asked me a confusing question, which I was worried about. He asked me how he will be treated. Well, as I have mentioned, the scenario was totally confusing. The task was just to persuade the surrogate for the investigations, for the diagnosis to be made. Until and unless, because you see, in secondary hypertension, until and unless you figure out the underlying cause, you cannot give them the treatment plan. Like secondary hypertension can be due to many causes, like hyperaldosteronism, pheochromocytoma, renal-artery stenosis, and so forth and so on. Until and unless you figure out the underlying cause, you cannot give the definitive plan. So when the surrogate asked me how he will manage, treat it, I didn't know the answer. Anyways, I told them it depends on the underlying condition. We'll be sending you and ask you to make your BP chart, blood pressure chart. And as soon as the investigations arrive, we will have another chat. The surrogate seemed satisfied and asked me to give them pamphlet. But I don't think the examiners were satisfied. They deducted some marks, but I think it was doable. This is my feedback. Now my final substation, the respiratory station, it was a short case. The patient was wearing a mask. He might be infectious, that's why he was wearing a mask. I completed my examination and my only findings were core scraps throughout the chest, more on one side of the chest than on other side. I don't remember again which side because it's been quite a while now since my examination. And another finding was scattered wheezing. So I told the examiner my possible list of differentials, which were bronchiectasis, infective exacerbation of COPD, and severe case of ILD. Because in ILD, when traction bronchiectasis develops, you can also get core scraps. So I mentioned that too. The examiner started asking me a question about bronchiectasis. Then they asked me, what is the most probable cause in Pakistan? I told them tuberculosis. They started taking viva about tuberculosis, about its management, about drugs, their do's and don'ts. Here the bell rang and I was supposed to go out, and I was, but one of the examiners, the other examiner who was not asking question previously, stopped me and asked me. He was like, one bonus question for bonus marks. And he asked me what are the precautions regarding tuberculosis medicines. I think I had already answered them earlier. Still, I started answering, but the lead examiner stopped me right there. In fact, he stopped the other examiner too and said, sorry, the time is up. So I came out and that was all. This is my feedback. They deducted 1 mark. I think the other examiner who was saying bonus question for bonus mark, I think he was the one who deducted that mark. But overall, it was quite perfect. I passed this exam with quite a good score, 158 by 168. But when we were done with the exam and we met other candidates, they had their own set of findings. It becomes so much confusing when you meet other candidates that your whole performance shatters down. One way to tackle that is you shouldn't meet other candidates, but it seems quite impolite. Anyways, for the whole duration till my exam result, I was so confused. I was like 70-80% sure that I might get through it, but still there was some ambiguity. But when the result came, I passed. Alhamdulillah. Of course, a lot of you might want to ask about my resources of preparation. In fact, a lot of candidates who have exams ahead have already asked me. So my resources were mock exams, one-to-one mock exam conducted at CMH, Lahore, one at Rawalpindi too. These are like exact real format. One mock exam I participated at Fast Paces Academy by Dr. Imran Babar. It's also good. Other resources I used were past test videos and videos by Clinical Skills Pro. These are also good, but I think the Clinical Skills Pro have really good videos on communication. Books I used were Cases for PACES and An Aid to PACES by Writer. Now, the most important resources you need are a good study partner, because a good study partner who has the goals and ambitions aligned with yours is not less than a blessing. I would suggest that you practice with your study partner on daily basis. And in fact, you can get the printout of the feedback form. And while you're practicing, no matter whether the communication or long clinical consultations, or when you are practicing on real patients, like for short cases, you take turns and one becomes the examiner, one the candidate, and you mark each other on the feedback forms in each skill. That is going to help you a lot, trust me. In fact, you can save those feedback forms you make during your prep, and at the end, like when your exam is approaching, you can go through them quickly too, right? And finally, you need luck, a lot of it, because without luck, I don't think even I would have been able to get through it, because I have seen candidates, just average candidates, who pass this exam. And I have seen candidates, like really good candidates. In fact, some of them are at senior level, expert level of their career, like assistant professors, associate professors, and still they cannot get through it. Sometimes maybe because the patient selection at the exam center is not so well. Sometimes just luck is not with you. In fact, the first few stations when you start your exam also determine how is it going to be. Like in my case, the first few stations went really well. In fact, I scored full in 4 stations. But if my exam started from station 1, the secondary hypertension station, which was full of ambiguities, I don't think I would have been able to recover for the next few stations. So you really need luck. Without it, I don't think anyone would be able to get through this exam. So this is it. This was my experience. I hope you enjoyed watching both videos. If you have any question at all, you can contact me. Also share the videos with your colleagues who are appearing in the exam.